Welcome to the GUMS GIT review lecture. As always, there's timestamps in the description so you can skip to a certain topic that you want to focus on. So this lecture, we're going to quickly just go over the important pieces of embryology in one slide, then cover the basic physiology and some high-yield conditions from each part of the tract, and then finish off with some clinically relevant points. So in terms of embryology, the things that you need to take away from this year are that there are a foregut, a midgut, and a hindgut. And the foregut is everything from the mouth to D2. The midgut is D2 until sort of 2/3 of the transverse colon. And then the hindgut is everything distal to that. Each of these embryonic areas have a artery, a nerve supply, and a lymphatic supply. And it's very easy to remember because it's the same name for each thing. So in the foregut, the blood, the nerve, and the lymph is all the celiac. So the celiac artery, the celiac plexus, and the celiac nodes. The midgut, it's the superior mesenteric, and the hindgut, it's the inferior mesenteric. The sympathetic plexus is named in that way, but you'll note on this diagram that the parasympathetic supply to the foregut and midgut is from the vagus branches, but the hindgut is a bit too distal, and so it gets its own supply from the parasympathetic sacral roots S2, 3, and 4 in their separate plexus. And that's really all you need to take away from it is, you know, if you get asked, oh, what's the blood supply of the appendix? You know that the appendix is on the cecum. You know that that's between the D2 and the transverse colon. So the appendix is a midgut structure. So its blood supply must originate from the superior mesenteric artery, and its innervation must be from the superior mesenteric plexus. So sympathetic innervation, which typically carries pain, will be in the T10 to T11 area, which lines up really well with where the pain goes to when it becomes somatic appendix pain. So that's the basic that you need to take away from embryology. Let's talk about the esophagus. So we've got some physiology concepts very briefly, and then some conditions. And some of these conditions are more high yield than others, and I'll point that out as we go. So in terms of physiology, I just wanted to remind you that peristalsis is a thing, right? That's all. And that there are 3 sites of narrowing in the esophagus. So you know how the ureters have that as well, and so they're the sites where a stone will likely get lodged in the PUJ, the VUJ, and then as they go over the iliac crest. A similar concept in the esophagus is that there's the upper sphincter where it crosses over the aorta and the lower sphincter. So if someone swallows something and it gets stuck in their esophagus, those are the 3 sites where it could get stuck. In children, it's most commonly the upper sphincter, and in adults, it's most likely to be in the distal esophagus, where there might be a tumor growing somewhere near the lower esophageal sphincter, for example, adenocarcinoma. The lower esophageal sphincter is a physiological sphincter. It's not really an anatomical structure as such, but it's a combination of 4 main elements. That the esophagus enters the stomach at an acute angle, which makes it harder for food to get regurgitated from the stomach into the esophagus. The intra-abdominal pressure pushes down on the intra-abdominal portion of the esophagus. There's mucosal folds, which act like valves, and there's the right cross of the diaphragm. So let's start with our first sort of condition and presenting complaint. So odynophagia is when someone gets pain when they try to swallow. And that typically implies inflammation of the esophagus, esophagitis. So things that can cause that are GORD, so that's reflux esophagitis, infection, especially if you're immunocompromised with HIV or corticosteroids. You can get esophageal candidiasis, various herpes viruses and cytomegalovirus, CMV. Pill esophagitis, especially with doxycycline and bisphosphonates. Eosinophilic esophagitis in people with lots of allergic conditions. Or, someone could have a cancer that's eroding into the wall of the esophagus, and whenever food passes through that area, it's kind of ulcerated, and so it hurts. So adynophagia is painful swallowing, which can typically be secondary to esophagitis, whereas dysphagia is difficulty with swallowing, not necessarily hurting, it's just that the food gets stuck and it feels like it's not going down properly. And there are two versions of that complaint because people eat and drink. So if they're having trouble just with eating, but drinking is okay, and especially like big chunky things like bread and meat in the past, that suggests that there's a physical blockage in the esophagus. So liquids can seep through whatever little gap there is, but big pieces of steak get stuck on top of the tumor. So that suggests tumor. So someone who says that they have just over the past few weeks lost a lot of weight, whenever they eat bread, it doesn't go down, but they don't have any other troubles, that's a bit worrisome. But if someone has dysphagia whenever they try to swallow liquid or solid, that suggests that from a muscular point of view, the esophagus isn't working properly, because anything that goes in the esophagus, the muscles are just spasming and spitting it back up or not adequately peristalsising it down to the stomach. And the conditions you should be aware of are achalasia, that's the one you should know really well, diffuse esophageal spasm, which is just a differential for achalasia, and Crest syndrome, which is something that you'll know about in the future. Maybe it's, medicine, there's a lot of things that you could know, and you probably don't need to know them all. Cancer. The main thing to know here is that in the upper 2/3 of the esophagus, where people, drink and they smoke and they get hot drinks, that's the first area that gets exposed to all that stuff, right? Because it's near the top of the throat. That's where you get squamous cell carcinoma. It's associated with alcohol, smoking, hot drinks, even achalasia. So people with achalasia can go on to get cancer, so they need to be monitored and get surveillance for that. Chemicals, and this condition called Plummer-Vinson syndrome is associated with cancer. Radiation exposure to the, say someone's having radiation for a head and neck cancer, their esophagus will be in the way of that beam, and then later in life they might get cancer from that. And it responds well to radiation therapy. Adenocarcinoma typically arises in the lower third of the esophagus, and it's associated with Barrett's esophagus, which is that squamous to intestinal metaplasia secondary to reflux esophagitis in people that have GORD, and that typically needs surgery to be removed. So what is GORD and what is Barrett's esophagus? Well, GORD is when you have reflux, but it causes symptoms and potentially clinically significant change to the esophagus. Where, someone who just has reflux, it's just that symptomatic. Every so often they regurgitate something because they drank too much or they bent over at a weird angle. GORD as a disease is when it keeps happening again and again, and it's painful and it's burning and you get issues. So it's an actual disease. It can be associated with substances like caffeine, smoking, and alcohol, which all have effects on the function of the lower esophageal sphincter, obesity, pregnancy, and many other things. The chronic reflux of GORD, the esophagitis from that leads to Barrett's esophagus, where you get this intestinal metaplasia of the esophageal mucosa. And the Z line, which differentiates the squamous cells from the intestinal cells, the columnar cells, that climbs higher as you get this metaplasia going from the cells sort of at the junction, climbing up the lower third of the esophagus. And that area is where you can get cancer happening in the future. So people with GORD need to be on PPIs and treated, and change their lifestyle so that they don't get Barrett's. And then once they do have Barrett's, they need regular endoscopic surveillance to make sure that that doesn't become cancer. And there are various procedures and surgeries you can do to intervene in this condition. Let's talk about esophageal varices. So what is portal hypertension? As always, you should try to be systematic in the way you learn things because you'll remember it better, and doctors won't listen to you unless you're systematic. That's just life, unfortunately. So let's break it up into prehepatic, hepatic, and posthepatic. Now, this is different from most directions of things. In my brain, prehepatic should be on top and posthepatic should be coming out the bottom. And that's how it works for jaundice. But in this case, you got to think the prehepatic blood flow is actually the portal vein coming in inferiorly. So it's prehepatic into the bottom of the liver. And that's things like portal vein thrombosis or splenic vein thrombosis, which can extend into the portal vein because, the portal vein is the connection between the SMA and the splenic vein heading into the bottom of the liver at the triad. Within the liver itself, if you have cirrhosis or some infections in third world countries or cancer, that can increase the pressure inside the liver. And then you can have posthepatic, which in my brain, posthepatic, I think of it as the portal vein, but I need to remind myself, and that's why I put it in bold here, the posthepatic causes are those in the hepatic vein on top of the liver as it joins the inferior vena cava. So there's things like Budd-Chiari syndrome, or Chiari, however you want to say it. Read a little bit more about that because it comes up quite a lot. Right heart failure and constricted pericarditis. So these are the things to do with blood getting from the liver back to the heart. Those are the posthepatic obstructions. So all of these things obstruct blood flow from the portal vein, whether it's, where the portal vein meets the liver, or in the liver itself, or somewhere after the liver. The pressure within the portal vein increases, and the portal vein has connections, portosystemic anastomoses, to systemic circulation, and that results in a few clinical signs that you should be aware of. So because you've got sort of a reversal of the pressure gradient, those points of anastomosis bulge out and become varicose. At the paraumbilical veins, where they meet the epigastric veins, you get caput medusa. In the rectal circulation, you get hemorrhoids or anorectal varices, which are they're not the actual hemorrhoidal pillars, it's other veins, but still looks like hemorrhoids. And also, I was in a room full of surgeons this year, and they said, do you guys think that this idea that cirrhosis causes hemorrhoids, or that hemorrhoids are a meaningful sign of portal hypertension? Do you think it's true? And all the surgeons said no, they've never seen it in their life. So maybe it's not actually a very valuable sign, but it's taught anyway. And then at the sort of bottom portion of the esophagus, there are another anastomoses there, which can bulge and form esophageal varices. And they're important because they can rupture and lead to a massive hematemesis. And you can lose a lot of blood in that vomit. So the treatment for that, interestingly, involves drugs like terlipressin and octreotide, which you should Google them. But it's not for, what they are. It's that they happen to, for some reason, preferentially vasoconstrict the splanchnic circulation, which is all of the circulation that connects to those anastomoses. So it decreases blood flow and will ultimately decrease blood flow into the varice. You can then go endoscopically in and put a rubber band around the varice or burn it, or somehow obstruct flow. And then in the long term, you can prophylax them with propranolol, which will essentially lower the pressure inside the varice through a combination of lowering systemic blood pressure and also vasodilating a lot of capillary beds. And obviously, if they're bleeding out, then you need to give them blood and platelets and fresh frozen plasma. And there's a good piece of advice when it comes to, do you give someone fluid or do you give them blood? the surgeons will say, well, if someone's dehydrated, give them fluid because they're low on fluid, but if they're bleeding out, give them blood. It's just whatever they're low in, you give. So should you give the person blood? Well, are they bleeding? Yeah, give them blood. That's kind of a different mindset than what the hematologists have, where they have pretty strict criteria on whether or not you really need blood. But anyway. Esophageal dysmotility. So this was the one we talked about with dysphagia as the primary complaint, where it's dysphagia to both solids and liquids. You've got achalasia and diffuse esophageal spasm, which can both be treated with calcium channel blockers. And then there's an interesting syndrome called CREST, which there's a family of conditions called sclerosing conditions. So scleroderma is sort of the umbrella term that includes systemic sclerosis and CREST syndrome, which is a sort of, I think it's called a focal sclerosis or a system. Yeah, it's the one that isn't everywhere. The C is for calcinosis, R is for Raynaud's, which I've spelt wrong there, O for esophageal dysmotility, sclerodactyly, and telangiectasia. So this is an interesting thing, and I've actually got a patient in the hospital with this. So the calcinosis, if you Google them, they're like these little lumps that once you see them, you know what they look like. Raynaud's is that phenomenon where it gets cold and then your fingertips go cyanized. Esophageal dysmotility is what it sounds like. Sclerodactyly, you get these long sort of stretched out skin on the fingers that makes them look just kind of strange, kind of leathery, I guess. And then telangiectasia are those little sort of red lesions that you might see in the lips or ears and other places. So the reason I say all this is that CREST syndrome can present with esophageal dysmotility, and yeah, this guy, he has that. Here are two barium swallow x-rays. On the left, you've got the bird beak sign of achalasia, so it comes down to the point. And on the right, you've got the corkscrew pattern of diffuse esophageal spasm. These aren't really questions in Australia. You just focus on the achalasia, but for people doing USMLE, they often get you to compare these two images and diagnose based on the image. Zenker's diverticulum, you've learned about in anatomy, so revise, which parts it's popping through, but it's essentially an outpouching of the posterior pharyngeal wall, and food can get trapped there, and then you end up regurgitating this undigested food that smells really bad, and your breath will smell really bad. Just be aware of that. And for the people doing USMLE and gunning it, there are two syndromes that you should be aware of for the esophagus. CREST syndrome, as we said, and Plummer-Vinson syndrome, which is a triad of dysphagia, upper esophageal webs, which webs are just sort of, these folds of tissue within the esophageal mucosa, and then iron deficiency anemia. So someone who has difficulty swallowing with iron deficiency, you should suspect that it could be Plummer-Vinson syndrome, which can predispose them to cancer. Let's talk about the physiology of the stomach very quickly, and then briefly go over peptic ulcers and pyloric stenosis. In terms of physiology, there are a few different cells that are important to understand. There are the enteroendocrine cells, of which there's quite a few, and they release the sort of factors like histamine, serotonin, somatostatin, and importantly, gastrin. Parietal cells, which respond to these signals and produce stomach acid and intrinsic factor, and chief cells, which produce pepsinogen, which will then be converted to pepsin in the presence of the hydrochloric acid secreted by the parietal cells. The roles of the stomach are to absorb some things like medications and alcohol, to store food. So if you've eaten a large volume of food, you don't want all of that to go into the duodenum at once. So the stomach is a large stretchable chamber that can hold onto that food and slowly, intermittently release it into the duodenum via a reflex. And then intrinsic factor being produced by parietal cells is essential for the absorption of vitamin B12 from oral sources. and B12 together with intrinsic factor gets absorbed in the terminal ileum. But if you don't have the intrinsic factor in the stomach, if that B12 just makes its way to the ileum, it won't be absorbed. And that's where you get the condition pernicious anemia, where you have an autoimmune interference in the role of intrinsic factor, either by preventing it from being made or by preventing it from actually being active. And you get poor B12 absorption, you end up with a macrocytic anemia or the megaloblastic B12 deficiency picture. But we specifically call it pernicious when it's this autoimmune condition. It's the most common, but obviously if someone's, say, a vegan and they don't take B12 and they're getting none from any other sources, then that person will also have a B12 deficiency anemia, but technically that shouldn't be called pernicious anemia because in that person they don't have an autoimmune disease, they just have B12 deficiency from diet itself. Let's talk about ulcers. So peptic ulcer disease is the umbrella term for both gastric and duodenal ulcers. And the key thing to know is that gastric ulcers hurt as soon as you eat, more or less, because there's stomach acid being released when the food is going down. Whereas duodenal ulcers, when you eat, they end up getting relieved because you get the release of that bicarbonate fluid, which is soothing to the duodenum. And that's where the old statement, feeding the ulcer, comes from. So food makes gastric worse, but it makes duodenal better. Drugs can cause ulcers. NSAIDs are notorious, but also steroids and antidepressants. And importantly, the Helicobacter pylori thing, which, it's amazing that it was discovered, but then now I think a lot of doctors are finding that people are undergoing this Helicobacter eradication therapy without a clear clinical goal. So it's brought a lot of answers to the world of peptic ulcers, but then it's also caused a lot of trouble for the world of hypochondriacs who, want to get rid of this bug, and people that want to sell them stuff to make that happen. Why do NSAIDs cause ulcers? Well, COX-1 protects the mucosa and it gets inhibited if you take a COX inhibitor that's non-specific. So revise the fact that COX-1 is physiological. It's the target of aspirin when you want to block the physiological activity of a platelet, whereas COX-2 is the pathologically active one that's, a mediator of inflammation, and that's the target of NSAIDs when you want analgesia for, inflammation. So here's just an amboss table summarizing that in both forms of ulcers, obviously you get dyspepsia and discomfort when you eat food and you don't want to eat as much as normal, and there's like a gnawing pain somewhere in the epigastric region. It gets better with antacids, which can help to differentiate it from a heart attack, but obviously the patient population that gets reflux, ulcers, and heart attacks are all pretty similar. It's like 60-year-old men that drink and are obese, and so they've all got a bit of GORD and a bit of ulcer disease because they take their NSAIDs for arthritis from being obese and so on and so forth. So that idea of, if it gets better with nitrates, it's cardiac. If it gets better with antacids, it's a gut thing. That's obviously not realistic. Someone, even if it sounds like heartburn, they should be investigated for heart attacks because it could be. They might be bleeding. They might be anemic if they've got this ulcer that's just slowly oozing blood out over the months. The difference, as we said, is this pain after eating for a gastric ulcer, whereas the pain gets better with food in duodenal. And you should be aware of the urea breath test for Helicobacter pylori. And what basically happens is it takes about 20 minutes. You take a capsule of radioactive urea, and then the Helicobacter have an enzyme called urease, which will break down that urea, producing radio-labeled carbon dioxide because it uses the same carbon that was in the urea. And then you breathe that out into a bag, and if they detect the radioactive CO2, then they know that there must have been some organism in your stomach that had a urease activity to convert the urea into CO2. So that's one way to confirm the presence of Helicobacter pylori, but you can get false negatives and false positives if you are on antibiotics or PPIs. So you need to basically stop your medications in terms of antibiotics and stuff for 4 weeks, stop your PPI at least 1 week before, and stop things like sucralfate 2 weeks before. You don't need to remember that, but it's kind of a common clinical question of, if you're a GP and you want to do this test, what should your patient do with their medications? They might take their pantoprazole every day for the past year. So you need to make sure that they stop taking it before the test, or else it'll be a waste. Here's Niru's slide from pharmacology, just summarizing all the different areas through which the medications for gastric ulcer disease act. The important ones would be obviously the PPIs, the antibiotics and bismuth, the role of antacids, the pathological role of NSAIDs, and the sort of extra drugs, which are misoprostol and antihistamines, but not the normal antihistamines that you're used to. It's antihistamines for the H2 receptor rather than the H1 receptor. Here's that just nicely summarized. So things that stop acid coming out are PPIs and antihistamines, as well as the misoprostol. Things that protect the mucosa are stuff like sucralfate and bismuth, which sucralfate's it's the jelly stuff that coats the gastric mucosa. You've got your antacids, and then you've got drugs for H. pylori, which are antibiotics and bismuth. Here's the first-line triple therapy for someone who has H. pylori and a ulcer. You put them on a PPI. Esomeprazole is for some reason favored. Plus amoxicillin plus clarithromycin, and that whole thing they do for a week, and it comes in a combination package now from the pharmacy. This X-ray shows double bubble, and the diagram on the right suggests what we're talking about: projectile vomiting in hypertrophic pyloric stenosis. It is a good point that a lot of concerned parents will say, "Oh, my child projectile vomited it." And it's like it went a meter or something at most. But projectile vomiting is like, it's a hose firing across the room with intense pressure. So the features, typically it's kind of early in life, but it's not right after birth. So the baby's gone home by this point. But you feed them and then they vomit, and there's no bile. But it's, and by the way, bile is green, okay? Bile is not yellow, bile is green. That's something that, for some reason, in my head, I thought bile was kind of yellow, and I think a lot of people thought bile was yellow, and then the surgeons are like, hey, by the way, bile is very green, and then they show you like a picture, and it's like this bright green substance. They've got non-bilious vomiting, obviously, because it's a blockage at the pylorus, so it's impossible for any bile to be there because that's at the level of the duodenum. There'll be an olive-shaped thickened mass, which is, you're actually feeling the thick pylorus there up in the top of their abdomen, and you might actually feel a peristaltic wave going across the stomach trying to push food through that hypertrophic pyloric sphincter. There'll be what you call a hungry vomiter, that they really want food, they'll vomit, and then they want it again. So they don't present as like a child with gastroenteritis who feels sick from having stuff in their gut. They're really hungry. And they can get really sick, really dehydrated, and lose a lot of weight because they're just constantly vomiting fluid from their abdomen. If you regularly vomit for any reason, you end up losing chloride because of the hydrochloric acid in your stomach, but then that also volume depletes you, which causes the release of aldosterone via RAS, and then aldosterone acts at the kidney to cause loss of potassium and hydrogen in the urine, and together that's hypochloremic, hypokalemic metabolic alkalosis. That's the phrase you need to remember if a surgeon ever asks you about pyloric stenosis. But it's the same thing that will happen in someone who's bulimic purging type, because they are regularly vomiting in the same way. I just put this slide in here because, I found pediatrics really hard this year because I knew nothing. So at least here's a summary of some of the things that you should be aware of, that, you need to be able to differentiate vomiting in a child, whether it's bilious or non-bilious, whether it's projectile or not, whether the abdomen's distended, if they have an obstruction, or if it's a volvulus. At least the difference between pyloric stenosis and midgut volvulus would be really good to understand. Let's talk about the small intestine. So physiology, I've actually put most of it in with the pancreas because that's sort of where these chemicals do stuff. So please go to that slide if you want to review that. And then let's talk about some high yield conditions. So celiac, Crohn's, volvulus, obstruction, which I've put obstruction down the end with the other clinical things. And then very briefly, let's talk about Meckel's diverticulitis. So here's a diagram of celiac from the clinical medicine textbook. So if we follow this flowchart, you've got gluten, which becomes gliadin, and then gliadin becomes deaminated via an enzyme, and that then reacts with the immune system, and you end up with a couple of things happening. So the antigen presenting cell presents the deaminated gliadin to T cells. The T cells will release cytokines which cause changes to the mucosal cells, but at the same time the T cell will talk to the B cell and cause isotype switching in the B cell to promote the production of antibodies. These are the antibodies that we test in celiac. But it's these cytokines interacting with the epithelium that actually make all of the changes that you see histologically. So the loss of villi, the crypt hyperplasia, and the migration of intraepithelial lymphocytes, that's all happening because of the cytokine sort of inflammatory reaction. Why does celiac happen? Who knows? There's all those genes, and an important thing to understand about celiac is that there's a predisposition to autoimmune disease that comes as like a cluster of Graves' disease, celiac disease, and type 1 diabetes. They all kind of interrelate, and the incidence of each disease is more common if someone's already got, say if someone had type 1 diabetes, you can bet that their mother had Graves' disease or something. Not exactly like that, but there is a strong genetic involvement here. So the symptoms that you should be aware of are obviously steatorrhea, because you've got intestinal malabsorption, you're not absorbing fat, you get these fatty stools. You're then not absorbing fat-soluble vitamins A, D, E, and K. You're not absorbing iron, you're not absorbing B12, you're not absorbing calcium, so on and so forth. You'll have fatigue, weight loss, iron deficiency, fatty, foul-smelling stools, flatulence, abdominal bloating, and there's quite a few other extraintestinal symptoms and relations, but another thing to be aware of is this IgA deficiency that accompanies celiac. So one of the antibodies we test in celiac is an IgA antibody, but in people that have celiac, for some reason there's an associated potential for IgA deficiency, which means you could end up getting a false negative, because even though they have celiac, they've got IgA deficiency, and when you go to test the IgA antibody, they don't have it because they just don't have any IgA antibodies. So that's something to be aware of, that we'll test the IgA levels in a say a teenager at the same time as testing their anti-trans anti-TTG and the other antibodies, anti-endomysial, and so on. So yeah, just be aware of the thyroid disease, type 1 diabetes, celiac, fatty stools, diarrhea, nausea, vomiting, flatulence, failure to thrive, vitamin deficiency, iron deficiency. You think of this in sort of adults, but if you think about it in like a toddler even, they might present to the pediatrician not meeting their growth milestones and just being really tired all the time. You should suspect that it could be celiac if they're also having diarrhea. Let's talk about inflammatory bowel disease now, and I'm going to cover both Crohn's and ulcerative colitis in this small intestine section, just because I think it's good to talk about them at the same time to make sure you're clearly, these are both kind of two halves of one disease, and you should always talk about them at the same time to make sure that you know the differences between the two. So let's start with Crohn's. The symptomatology in terms of defecation, you have more bowel movements, but obviously it's the small intestine that's mainly involved in Crohn's. And when I say that, Crohn's can affect it anywhere from the mouth to the rectum. But, traditionally it's somewhere in the small intestine when you're comparing it to ulcerative colitis. And because of that, there won't typically be much blood because you don't have any like lower large intestine sigmoid rectal inflammation, the proctitis that you get with UC. So you're just getting lots and lots of diarrhea. So in a sense, it looks very similar to celiac. Whereas in UC, you've got a really irritated rectum. You're going to be having diarrhea all the time because that fecal reflex is just firing like crazy with the irritation. And there'll be blood and mucus from that inflammatory process. And you'll never feel like you've fully emptied your rectum, and you'll get painful defecation. In terms of nutrition, because Crohn's affects the small intestine where you do most of your nutrient absorption, you'll be malnourished. Whereas ulcerative colitis, you barely absorb anything through that lower distal portion of the large intestine, that it's very rare that you would have malnutrition. On physical exam, Crohn's disease typically has pain in the right lower quadrant. And in fact, it's so commonly in the right lower quadrant that it can be mistaken for appendicitis. So you should be aware that one of the differentials for appendicitis is Crohn's disease, even in a child. Whereas for ulcerative colitis, the pain tends to be in the left side, where the sigmoid and rectum lie in the abdomen, and you get lots of cramps and tenderness. And the main thing is painful defecation in UC. There are manifestations outside of the intestinal tract, and one important thing to note is that people with primary sclerosing cholangitis, most of them have ulcerative colitis. So there's a relationship between those two diseases. The things outside are basically just inflammatory signs. So erythema nodosum and pyoderma gangrenosum on the skin, uveitis in the eye, ulcers in the mouth, and arthritis and spondylitis, and sacroiliac involvement is quite common too in IBD. Fistulas are more common in Crohn's, and also abscesses and perianal fissures and strictures. So all of the sort of the best way I remember this is the radiological feature that Crohn's has the string sign from the stricturing of the abdomen. And just to remember that there are fistulas that, they can go between the GIT and the bladder, or the uterus, or the skin. Whereas UC doesn't really do that. It more has things like toxic megacolon and the really severe colitis that can kill you. They can both result in higher incidences of cancer, but the Crohn's disease is more going to cause lymphoma, and the ulcerative colitis will cause cancer in the large intestine. So that's sort of a summary of the clinical things. Let's break it down into a way that you can remember. Crohn's is from the mouth to the anus. Ulcerative colitis is from the rectum up. And it typically only goes as high as the cecal valve. But there can be some what you call backwash ileitis, where a little bit of it goes into the small intestine, but generally UC will never affect the small intestine, except for just that little bit of ileal inflammation near the cecal valve. In Crohn's, you'll have poor nutrition, and in UC, you'll be okay. In UC, you get more bowel symptoms in terms of bloody diarrhea with mucus. The pain of Crohn's is on the right and the pain of UC is on the left, which you can remember because the rectum is on the left. Both conditions cause issues in the skin, eyes, mouth, and joints. The key thing about Crohn's is that you get fistulas, strictures, and abscesses. Both of them cause cancer, but in different spots. And the other thing is the sort of pattern. That's another really good one to remember, that the typical location of Crohn's will be in the ileum, and it can be into the colon, but it doesn't go to the rectum so much. But you can get it, obviously these perianal fissures, so there's anal involvement. But it can go from mouth to all the way at the end, basically. And there are skip lesions throughout. Whereas ulcerative colitis is isolated to the large intestine, starting at the rectum, where it climbs its way up, and it climbs in a continuous fashion. So there's no gaps in the inflammation of ulcerative colitis. The buzzwords for Crohn's are cobblestone, string sign, transmural inflammation, granulomas, whereas ulcerative colitis, the main thing is that it's continuous, large intestine. It has crypt abscesses, but there are more general abscesses in Crohn's, and the lead pipe sign. The final important thing is that Crohn's is transmural inflammation, and ulcerative colitis is just the mucosa and submucosa. So if you get shown a histology slide where the lesion goes all the way through all layers of the gut, then it's Crohn's. Diagnosis is made. If it doesn't, then it could be ulcerative colitis. The treatment, obviously you don't need to remember this, but basically in an acute flare you can use anti-inflammatories like corticosteroids, but in the long term you want immune system modulating drugs or other forms of drugs like 5-aminosalicylic acid, 5-ASA. These are basically just anti-inflammatories that can be given rectally but also orally to kind of dampen down the inflammation. There are some biological drugs against TNF-alpha, and then surgery can be, quite a big component to IBD. In someone with ulcerative colitis, you can actually cure them if you cut out all of the sort of lower large intestine, and then you give them a colostomy bag. In someone with Crohn's, you might have to do surgery, and you don't want to do surgery. You want to preserve as much of the intestine as possible because you want to prevent malnutrition. But if someone's having, for example, strictures that are leading to obstruction, then the obstruction could kill them, so you need to remove that portion of bowel. And there's all sorts of stuff that you could learn about ileostomy versus colostomy and the sort of formation of a new rectum and things like that, but save that for surgery in third year. Here is a midgut volvulus secondary to malrotation. So what happens here is that During embryonic development, the cecum is meant to descend inferiorly, but if that doesn't occur, you have a narrow base of the mesentery of the small intestine, and so it's predisposed to volvulus. You fix this with a Ladd's procedure where they remove the appendix, move some things around, and basically fix it. There's obviously more details to it than that, but I don't really like surgery, so I don't care. Here's a Meckel's diverticulum. So this is along the small intestine. The reason this is important is because you see these blood vessels in the diverticulum. What can happen here is that you get an ectopic gastric mucosa forming in the diverticulum that actually produces acid, and you'll get an ulcer forming here, and you get what's called Meckel's diverticulitis, and that ulcer can actually eat into this blood vessel, and you get a lot of bleeding from the small intestine. And that's, kind of a cause that you don't often think about of sort of, say, just below sort of periumbilical, but kind of superior to that, abdominal pain plus GI bleeding. Well done making it through our journey so far of the alimentary canal. Let's talk about some of the accessory organs, starting with the pancreas, with physiology and then two conditions, because you don't even really get that in medical school. Let's start with the physiology. So the endocrine pancreas, so there's an endocrine and an exocrine function. The endocrine function is from the islet cells, of which we care about the alpha and beta cells. There are also other kinds, I think it's a delta cell or something, but alpha and beta is what we focus on. Alpha cells make glucagon. Glucagon has the letter A in it, so I remember that it's for an alpha cell. Insulin doesn't have A or B in it, so you won't get confused there. Glucagon, alpha, done. Glucagon gets released when your blood sugar is low, and it promotes gluconeogenesis in the liver, glycogen breakdown in the liver and the skeletal muscles, all with the goal of increasing blood sugar. Interestingly, it's only the glycogen breakdown in the liver that actually gets released into the blood. The muscles are a bit selfish, and because of lacking a certain enzyme, the glycogen that gets broken down in your skeletal muscle can only be used within that muscle itself. But the liver glycogen breakdown can be freely released into the bloodstream. Beta cells produce insulin when your blood sugar is high, and that is basically with the goal to get that sugar back down by opening GLUT channels, GLUT channels in skeletal muscles to cause uptake of glucose to muscle. It promotes glycogen synthesis and it inhibits gluconeogenesis, all with the goal of storing up sugar so that it's no longer in the blood to reduce the blood sugar. And there's a balance between these two hormones and also adrenaline to keep things steady. The exocrine pancreas, the two sort of halves to think of are the enzymes and the juices. And whenever a protein-rich acidic chyme is released into the duodenum from the stomach, two hormones get released by the intestine, secretin and cholecystokinin. When secretin acts on the pancreas, it promotes the production and secretion of a bicarbonate-rich alkaline fluid into the intestine, and that neutralizes the stomach acid to protect the duodenum. And then cholecystokinin promotes the production and release of pancreatic enzymes for carb, protein, and fat breakdown, and they get released in the pancreatic secretions into the duodenum. So together, secretin and cholecystokinin will give you this alkaline fluid filled with enzymes that are ready to break down whatever just came from the stomach. At the same time, cholecystokinin promotes contraction of the gallbladder and relaxation of the sphincter of Oddi to allow the entry of bile into the duodenum to aid in emulsification of fat to allow you to break down fat. Pancreatitis is a acute inflammation of the pancreas, which is incredibly painful and can be life-threatening. And the causes of it, which you'll know this by third year, but you don't need to know it now. But I just wrote it so many times that I remember it. I get smashed. I for iatrogenic, so some people just get pancreatitis and we can't figure out why. Gallstones. So if someone has choledocholithiasis, where the stone is in the common bile duct, obviously the main pancreatic duct connects to the common bile duct to eventually get to the ampulla. If the stone is there distal to the connection between the main pancreatic duct and the common bile duct, then you can get pancreatitis because the pancreatic secretions are blocked and you get reflux into the pancreas itself and then it gets inflamed. Alcohol, trauma, steroids, mumps, malignancy, autoimmune, scorpions, hypercalcemia, hyperlipidemia, ERCP, which is a procedure we do in hospital. Basically, it's endoscopic retrograde cholangiopancreatography, where you put an endoscopic camera into the small intestine, poke a little arm of that camera up through the duodenal papilla, so the ampulla of Vata, go up into the main pancreatic duct a little bit, squirt some dye so that you can see the biliary tree, which in the process means some of that dye goes into the pancreas. And rarely that dye in the pancreas can actually cause pancreatitis. So someone could come into the hospital with something that looks like a gallstone in their common bile duct. You do an ERCP, and then you've given them pancreatitis, and now they have to stay in hospital for 2 more weeks while they get very, very sick. It's not good. The final one is drugs, and the way to remember the most common drugs is the acronym SAND. S for sulfonamides, so things like trimethoprim, sulfamethoxazole, and other older drugs. Azathioprine, NSAIDs, and diuretics, especially hydrochlorothiazides. So that's the causes of pancreatitis. The most common is gallstone pancreatitis, with alcohol being very close depending on what country you're in. What basically happens is the enzymes of the pancreas get activated inside the pancreas itself, either because it's blocked or it's just acutely inflamed. That damages the pancreas, and then you get an inflammatory response based on that damage. The pancreas gets more damaged. You get a massive release of inflammatory mediators into the circulation. You basically go into an inflammatory response where your blood vessels get leaky. You lose lots of fluid. You end up with fluid on the lungs and around the heart and leaking from the gut. You'll get very low blood pressure. Your kidneys fail because you're basically going into distributive shock, kind of like anaphylaxis. That pancreas tissue starts to die, and you can have bacteria growing in that necrotic tissue. And then as lipase gets leaked out and squirted over the peritoneum, that will begin to break down fats in your own tissues. And then the release of fatty acids will bind to calcium, and that calcium gets used up, and you can end up with a really severe hypocalcemia. And that's called fatty saponification, because when calcium binds to those fat salts, you actually form soap, in a sense. It's just crazy. Pancreatitis, I saw quite a few cases on surgery, and it looks like the worst pain I could have really imagined. And I've seen childbirth, so I think it probably looked worse than childbirth. I hope I never get it. The clinical features are a severe epigastric pain radiating towards the back, worse after meals and when you're lying on your back. It improves with leaning forward, and that's because when you lie down, your peritoneum is, sagging with gravity against the pancreas. When you lean forward, the peritoneum is a bit more forward, and so it's that peritoneum that gives you the somatic sensation of, the acute sharp pain. It's the visceral peritoneum that you'll feel all the time, but it's the leaning forward and back that changes how much your somatic sensation of pain will be felt based on the parietal peritoneum. Similar to how appendicitis begins with visceral irritation, with a visceral pattern of pain felt in the midline, sort of around the belly button, periumbilical region, which then navigates down, localized to the right lower quadrant as the inflammation begins to spread into the parietal peritoneum, which is somatically innervated. So generally the person will look shocked. They'll have low urine output, low blood pressure, high heart rate. They could be jaundiced if they've got a big stone blocking everything, so in gallstone pancreatitis. Their abdomen will be tender, they'll be guarding. If you percuss them, they'll get peritonitic, so their whole peritoneum is on fire. And they can end up getting bleeding from the leaking of blood products into spaces that aren't blood vessels. So Cullen's sign is bruising inferior to the belly button. Gray-Turner's sign is bruising in the flanks. And these signs are non-specific, so you could also get them from any retroperitoneal hemorrhage. But basically, in pancreatitis, they just suggest that you're basically losing blood from your blood vessels because they've become so leaky. Pancreatic cancer is just good to have a general idea that there's two forms of jaundice. There's painful jaundice and then there's painless jaundice. And painful jaundice is great. You've got hepatitis or you've got cholangitis from a choledocholithiasis that has gotten inflamed and infected. You can fix these things. Maybe not hepatitis, but yeah. Whereas if someone comes into emergency and they're jaundiced and very comfortable, you almost definitely know that it's a cancer of some kind, blocking anatomically the flow of bile. And that's most commonly a head at the pancreas of the tumor, but it can also be a tumor at the duodenal papilla or of the bile duct itself, a cholangiocarcinoma, which can either be a distal cholangiocarcinoma or a proximal cholangiocarcinoma relative to where it is near the liver. Let's quickly talk about the liver. So the physiology of the liver is beyond the scope of a medical course. There's like 120 different synthetic and metabolic functions of the liver. The ones we really care about, though, are to do with bilirubin, urea and toxins, drugs, clotting, and albumin. So we'll focus on that, but just be aware that the liver does so many different things. And, even in embryology, it's the main site of hematopoiesis before your bone marrow develops. So it can literally make red blood cells. It's incredible. And then we'll talk about some conditions in the liver. So liver function is a poorly used term. So typically when people say LFTs and liver function tests, they're actually talking about liver enzymes. Liver function, it refers to the actual function of the liver, whereas liver enzymes tells you nothing about how the liver's functioning. So liver function is what we used for the Child-Pugh classification of liver failure. The things you need are clotting factors, which you can test via the INR or prothrombin time, albumin levels, bilirubin, and then clinical features of hepatic encephalopathy or encephalopathy, however you want to say that. So synthetically, yes, it makes clotting factors, and that's where warfarin acts on those vitamin K dependent clotting factors 2, 7, 9, and 10. Albumin, and that's why you get ascites with liver failure from the low albumin and the loss of oncotic pressure. Metabolically, it conjugates bilirubin and does the whole bilirubin cycle. The urea cycle and breaking down toxins, and that's why liver failure leads to high levels of ammonia, which are toxic to the brain, and a lot of other metabolic things. Drug, phase 1 and 2 metabolism. Phase 1 is those CYP enzymes, and then phase 2 is the glucuronidation and other things to turn fat-soluble drugs into water-soluble drugs. many other functions. It's a god tier organ. It's OP. If you've got a good liver, you've got a good life. Liver enzymes. So liver function, liver enzymes. Liver enzymes are the AST, ALT, GGT, ALP. AST and ALT generally reflect hepatic damage, where AST is preferentially raised in alcoholic hepatitis. And in acute hepatitis, AST and ALT will be very high. So you might see in your PBL cases someone has like a ALT of 60. And it's like, cool. Show me an ALT of 3,000, please. The AST to ALT ratio, if it's greater than 2, strongly suggests alcoholic hepatitis, because the AST within the mitochondria of hepatocytes is particularly sensitive to alcohol. And I remember this because AST has the letter S in it, which in my brain stands for Scotch or sake. GGT or Smirnoff. GGT and ALP suggest a cholestatic pattern, damage to the biliary tree, and a loss of the ability to drain bile will likely follow elevation of these enzymes. That's all you really need to know. And the other thing to know about ALP is that it's released when bone turnover is occurring, which can be normal in children, but it could be a sign of bone metastasis in adults. So if you've got someone with prostate cancer metastasized to the bone, you would expect that they would have a high ALP and also a high lactate dehydrogenase, suggesting lots of cell lysis from tumor cells that are living and dying very rapidly. The human placenta also makes ALP, so lots of people in the 3rd trimester of pregnancy will have an elevated ALP, and that's okay. The only other thing I'll say is that GGT can be selectively raised by alcohol as well, so this pattern doesn't really work that well, and there are a lot of people in hospital when I've looked at their bloods that it kind of, they had a gallstone, but their ALT was really high, and it's just like, I don't know. So in the end, it's kind of, you need to tie it in with a clinical picture and then do some more meaningful investigations like a ultrasound looking for gallstones or an ERCP, a CT scan, and whatever other expensive things you can do in a first world country. Bilirubin. Total bilirubin is a combination of the unconjugated and the conjugated, which I've written the word indicated on this slide, but where it says indicated, that should say indirect bilirubin. It's kind of a combination of indirect and conjugated, that word I've made up. The unconjugated bilirubin, it's the bilirubin directly from the breakdown of red blood cells before it's been conjugated in the liver. If it's really high, that suggests that there's a lot of hemolysis going on, so much so that the liver can't keep up and it's unable to conjugate all of that unconjugated bilirubin. So having an elevated indirect bilirubin suggests hemolysis. And that's quite common in pediatrics when you have hemolytic diseases, or just can be normal to a certain extent when you have the transition from fetal hemoglobin to an adult hemoglobin with their immature liver. They struggle with that hemolysis. Conjugated bilirubin, if that's high, it means that the unconjugated has gone to the liver, been conjugated, been excreted into the biliary tree, and then it's been blocked. And then it's, gone back up, regurgitated into the bloodstream. That suggests a hepatic or post-hepatic obstruction, such as a stone, called choledocholithiasis, or an intrahepatic issue like cirrhosis, where the fibrosis blocks the actual sinusoidal flow of everything. And then look at genetic conditions to do with conjugation and bile excretion, Gilbert syndrome and Crigler-Najjar. Jaundice. Again, let's be systematic. We have prehepatic, hepatic, and posthepatic. Only this time, it's kind of upside down from portal hypertension, in that prehepatic refers to the arteries. Posthepatic refers to the stuff underneath the liver the biliary tree. So it's, prehepatic portal hypertension is the portal vein at the bottom of the liver, but post-hepatic jaundice is the biliary tree, also at the bottom of the liver. I don't know why that upsets me so much, but it's just, I think of pre to post being superior to inferior, and I like that for jaundice, that it kind of matches that. Whereas, obviously, the portal vein thing is upside down in my head. Prehepatic, hemolysis. Hepatic, cirrhosis, hepatitis, cancer, and those genetic conditions. Post-hepatic, anything that blocks biliary outflow. So stones, cholangitis secondary to the stones, pancreas, duodenal ampulla, biliary tree, tumours. How do you approach an adult with jaundice? Step 1, you say hello. Step 1, you do a physical examination. Look at the skin, the sclera, pull down their eyelids and get them to look up so that you see the sclera that doesn't get exposed to sunlight, just to, in case it's, rapidly broken down in that light exposed area, as some people say, which might be a myth because I don't think UV light actually does anything to bilirubin, but whatever. Get them to look up. Then look at their bloods. Firstly, you'll notice that the total bilirubin is elevated. Then you'll differentiate it based on, is it the indirect or direct bilirubin that's higher? Then look at the liver enzymes to suggest whether it's a problem in the liver or if it's drainage of bile that's the problem, and then make a conclusion. So let's look at an example. John is a 62-year-old male with a history of unintentional weight loss and early satiety, meaning he feels full sooner than usual. He has no pain, but he's recently noticed his urine is very dark and his stool is very pale. He ignored these symptoms, assuming that he was just dehydrated. On examination, he's peripherally jaundiced and has scleral icterus. He has a palpable painless gallbladder and an enlarged, soft, non-tender liver margin. His blood tests are as follows. He has a high total bilirubin. He has a markedly elevated direct bilirubin, which is the conjugated bilirubin. He has elevated ALP and GGT, which are much higher than his AST and ALT, suggesting a cholestatic pattern. His LDH is very high, suggesting a lot of cell lysis. Tumor marker CA19.9 is extremely elevated. He gets a PET CT scan, which shows a large FDG avid, which is just a terminology for PET scans, lesion of the pancreatic head with multiple avid lesions in multiple segments of the liver and aortic lymph node involvement. He has an endoscopy with fine needle aspirate biopsy through the wall of the stomach into the pancreas guided by ultrasound. Histological analysis of those cells confirms the diagnosis of a poorly differentiated pancreatic adenocarcinoma. John isn't a real person, by the way. This is just a made-up case. And then there is a tumor of the pancreatic head, for example. So that's the tail of the pancreas, the head of the pancreas, the liver, the gallbladder, the left kidney, psoas and quadratus lumborum, stomach with the bubble. Eventually CTs will make sense. They won't always. There's the left and the right. If you can get that part right, that's a good start. Let's talk about why he has dark urine and pale stools. And I really should have added a diagram about this, I'm sorry. When you have unconjugated bilirubin from the blood, it goes to the liver where it gets conjugated. That then gets excreted in the bile into the bowel. Then in the large intestine, gut bacteria actually act on that bilirubin. They convert it to another form, of which a certain amount will be reabsorbed through the bowel back into the liver, and that constantly gets recycled. And then some of it will stay, get oxidized, and form stercobilin, which gives feces its brown pigment. The other thing is that the sort of modified version from the bowel circulates in the urine, and in the urine it forms urobilin firstly urobilinogen, but it becomes urobilin in the kidney, and that helps to color your urine yellow. Okay, so putting all that together, if your bile doesn't get from the liver into the gut, you won't have the brown pigment in your feces and you won't have the yellow pigment in your urine. So you end up with, instead, the unconjugated bilirubin floating around the blood, getting turned in the liver into conjugated, leaking back into the blood, going out into the urine, giving it this dark color that makes it look like Pepsi, not having the urobilin pigment to make it yellow in any way, whilst also not having the stercobilin pigment in the feces, meaning your feces are very pale and white. So when you've got this obstructive jaundice, you end up with dark urine, pale feces, jaundice in the body, and an elevated conjugated bilirubin, which is the direct bilirubin. I hope that made sense. There's a brilliant, in Diane Moses's lecture, there's a really good diagram tying it all together. Let's quickly talk about neonatal jaundice, just to finish off jaundice. So there can be a normal jaundice that starts more than 2 days after birth, where it's just the breakdown of the fetal red blood cells with a combination of an immature liver. It can't keep up with that cell turnover, so you end up with lots of unconjugated bilirubin, but it's okay. And it can especially happen if they have a big bruise on their head from birth trauma, because those red blood cells will hemolyze eventually and also contribute. If it's less than 48 hours after birth, that strongly suggests that it's a pathological process, especially hemolysis from a blood group incompatibility with the mother that wasn't picked up, and there'll be a very rapid elevation of unconjugated bilirubin, which can, it can cause some serious conditions in the child that I talk about in the BMB review lecture for neurology, chronic bilirubin encephalopathy or something like that. It's essentially what used to be called kernicterus, where you get bilirubin pigment accumulating in your basal ganglia and you end up with a form of cerebral palsy called chorioathetosis. Breast milk jaundice and breastfeeding jaundice are two things to do with breast milk. So breast milk jaundice is actually about the milk itself, and that there are some enzymes in the milk that interfere with conjugation. And then breastfeeding jaundice is the fact that if a child is exclusively breastfed and the mum has poor milk production, the child will get dehydrated. That will impair blood flow to the liver and make conjugation worse that way. So they're two different things. One is the milk and one is the dehydration, because you're trying to be exclusively milk fed. Which breastfeeding is good. It's just you need to be aware that this is a thing that happens and it's fairly normal. And as soon as the baby gets a bit more hydration, they'll be okay. If they have jaundice that sticks around and it starts a little bit late, that strongly suggests that there could be something else going on, and you should investigate for biliary atresia, especially if they have genetic syndromes of any kind, because biliary atresia means that the bile is unable to flow because the biliary tree hasn't formed properly. Hepatitis A, B, C. A. Fecal-oral transmission in contaminated water can be prevented with a vaccine, doesn't cause cancer, just causes a bit of hepatitis and diarrhea for a while and then it resolves, and you should travel vaccinated. Hepatitis B, caused by blood, sex, and drugs. Vaccine preventable, but it can cause cirrhosis and cancer, and there's no cure. Hepatitis C, caused by blood, sex, and drugs. There's no vaccine, and it can cause cirrhosis and cancer, but now there's essentially a cure for it with some modern-day drugs. And in fact, non-alcoholic steatohepatitis from non-alcoholic fatty liver disease, it's going to take over hepatitis C as the leading cause of liver transplants within the next 5 to 10 years. Let's talk a little bit about non-alcoholic fatty liver disease quickly. So You begin with steatosis, which is the non-alcoholic fatty liver disease. There's fat accumulation in the liver cells. Eventually that leads to an inflammatory process in some people where they get non-alcoholic steatohepatitis, where there's an actual inflammation associated with the steatosis. Some of those people that get NASH will go on to get NASH cirrhosis and liver failure and eventually cancer. So this is why it's going to, take over hepatitis C as the leading indication for liver transplant. So what is cirrhosis all about? So you should know the clinical features of cirrhosis really well. It's one of the best sort of Oski station style things because there are lots of clinical signs that you can say that you're looking for. So fatigue and weight loss, obviously goes with any chronic disease. Jaundice, pruritus, the bilirubin pigments when they get deposited in the skin cause itching and it's terrible. There are a couple of different treatments for it, but I remember this guy that we had and he's just scratching his arms like crazy all day because of the pruritus from being jaundiced for so long. Hysterexis, which is the liver flap of the arms related to hepatic encephalopathy. Fetal hepaticus, which is this really bad breath that you get secondary to high ammonia. The ammonia interacts with gut, with oral bacteria and produces a foul odor, I think, something like that. Dupuytren's contracture of the hand in alcoholism. That's where if you turn your hand over and look at your palm, the medial aspect where your little finger and ring finger are, that tendon becomes shortened and fibrosed and your fingers go into a flexion contracture. Hepatomegaly, splenomegaly, and ascites. So splenomegaly secondary to portal venous hypertension because the splenic vein will get engorged and then the spleen will get engorged. Ascites secondary to low albumin from a failure of synthetic function of the liver. Skin changes, telangiectasia and spider angiomata, which they think may be to do with high levels of estrogen, which are secondary to estrogen not being broken down by the liver, which is also why you get gynecomastia and abnormal hair distribution. Caput medusa, which is one of those portal vein outcomes we talked about. Palmar erythema, which might be to do with estrogen. White nails, which is leukonychia, which might be to do with low albumin. And nail clubbing can also occur. The high levels of estrogen secondary to the failure to break down estrogen is what leads to gynecomastia, and in men, testicular atrophy, loss of body hair, palmar erythema, reduced libido, infertility, spider angiomata, and in women, loss of their menstrual period because high levels of estrogen will disrupt the normal menstrual cycle. The diagnosis. So don't worry about the diagnosis here, but the main thing to talk about is that the liver enzymes will be up, but not necessarily. If you've got chronic cirrhosis, eventually there won't be any more destruction because it's already destroyed, so the liver enzymes won't be markedly elevated. High bilirubin, which is a hepatic form, so it'll be mixed. You're not conjugating very well because you don't have much liver function, but you're also obstructed from the cirrhotic fibrosis. High GGT because of that outflow obstruction, and ALP for the same reason. Ammonia because of a failure of the metabolic function, and it's that ammonia that goes and makes the brain act funny in hepatic encephalopathy. Increased prothrombin time, meaning that you bleed more easily because you're not producing clotting factors. Low albumin, a macrocytic anemia due to vitamin deficiencies, a microcytic anemia, so you can get a mixed one here from blood loss from your varices and hemorrhoids and so on, and also having a chronic disease will form a normocytic anemia, so lots of different anemia etiologies at the same time. And thrombocytopenia because all your platelets get stuck in your big gooey spleen. So here's all of that in one diagram. So from the end of the bed, you should note that This person has a distended abdomen, palmar erythema, and jaundice. When you look at their hands, you note the palmar erythema. You look at their fingernails for leukorrhea. You notice on their arms for scratch marks to suggest pruritus. You get them to do the liver flap, and maybe they have it, maybe they don't. You travel up the arm, looking at the face. You look for scleral jaundice. You look in their mouth for poor dentition, and at the same time, you're looking for glossitis and angular stomatitis or cheilitis, suggesting iron deficiency or B12 deficiency. You smell the breath for fetor hepaticus. You travel down the neck looking at the chest for abnormal hair distribution and spider angiomata and gynecomastia. You make your way to the abdomen and you tap it, and it's a highly acidic abdomen with a fluid thrill present, and the fluid collects in dependent positions, which lead to dullness to percussion on the flank, which changes as you rotate the patient. The caput medusa are present at the umbilicus. There's scratch marks on the abdomen as well. The liver is enlarged on palpation, or if it's chronic, really severe cirrhosis, it might not be enlarged because its actual volume has shrunk. The spleen might be palpable. The legs are edematous from the low albumin, and overall, you might have a look at the testicles and they have reduced volume. You conclude without any blood tests, without any history, this person has liver failure, which could be from alcohol, could be from a virus. You could look for track marks if they're a long-term IV drug user. Or it could be some other condition such as autoimmune hepatitis. Let's quickly talk about the gallbladder. So the physiology is really just that CCK makes it contract and its job is to hold on to bile. It ends up getting stones and really hurting. It's not a very useful organ. Bile comes from the liver, gets stored in the gallbladder, gets released under the influence of CCK, which contracts the gallbladder, relaxes the sphincter, lets bile pass into the duodenum. You can live without it. Cholelithiasis is the presence of gallstones in the bladder. They might be asymptomatic and just found incidentally while doing something else. 80% of them are cholesterol and 20% of them are pigmented, which is often secondary to hemolytic disease, so it's bilirubin pigment that forms stones. Biliary colic, on the other hand, is when someone with cholelithiasis, that stone rolls around in the gallbladder and gets stuck in the cystic duct. And whenever that happens, they get pain because the gallbladder is becoming, a little bit irritated. But then the stone eventually rolls back out and it's okay. That person will have right upper quadrant pain from their gallbladder, but no fever, because there's no infection yet. It's just every so often it gets a bit blocked and it hurts a little bit. Those stones might pass, or those stones might just live in the gallbladder forever. Cholecystitis is when someone with cholelithiasis gets an obstructed cystic duct from that stone being, permanently stuck there. That obstructs the gallbladder, leading to inflammation, causing severe right upper quadrant pain, with systemic features like fever. It's the fever that differentiates it from biliary colic, because you've got an actual inflammatory process with infection going on. So cholecystitis, it doesn't cause jaundice though. That's something I didn't understand as a student. I thought, gallbladder, you get jaundice. The common hepatic duct is patent, right? So bile still drains freely from the liver. It's just the gallbladder that doesn't drain, and that's fine. People without a gallbladder don't get jaundiced. Jaundice only occurs if you block the common bile duct, which we'll talk about next. Porcelain gallbladder, I just want to talk about that in someone with recurrent cholecystitis or other things, they get chronic inflammation of the gallbladder and it then calcifies, and you get, on X-ray, you can see this radiopaque outline of the gallbladder. That's porcelain gallbladder. and it predisposes them to get gallbladder cancer, and it's an indication to get that thing out of there. Choledocholithiasis is when the gallstone has rolled from the gallbladder into the cystic duct and then into the common bile duct. And a stone in the common bile duct can cause jaundice, pain, and even pancreatitis. It can be removed with endoscopic retrograde cholangiopancreatography, and you can use a trawling net, which you blow up this sort of umbrella thing that will scrape all the sludge out of the common bile duct. And you can even pop a little stent in to make sure that bile drains while everything gets sorted out. It can be temporary, or if someone has cancer, you could pop in a permanent metal stent that will drain bile. Cholangitis is when someone has choledocholithiasis, they obstruct their common bile duct, it gets inflamed, and that inflammation and infection climbs up the biliary tree heading to the liver. It's typically E. coli in the biliary tree, and you can get such inflammation that the E. coli are able to jump from the biliary tree into the blood, and you become septic with biliary sepsis, which you would treat with antibiotics and ERCP with stenting to restore that flow of bile. Stagnant bile is where E. coli are able to grow. So as soon as you restore flow, you'll fix the sepsis, as long as you've got some antibiotics too. I just wanted to also define Moritzi syndrome, which is where you have a stone in Hartmann's pouch of the gallbladder. And it actually, because of the way the gallbladder sits next to the cystic duct and the common bile duct, that stone actually compresses the common bile duct and you get jaundice, even though you don't have a stone in the common bile duct. It's actually the stone in the gallbladder pushing from the outside against the common bile duct. The other thing you should know for anatomy is gallstone ileus, where you get a large gallstone penetrate through the gallbladder into the intestine. It gets stuck and causes paralytic ileus in the intestine. Let's quickly go over the large intestine. So the function is basically to absorb water and electrolytes, to give a home to your gut bacteria, and also vitamin K gets activated here. The functions, that's basically it, and to form stool, to keep you hydrated and to keep your electrolytes okay. Here are some slides that I wrote this year on the large intestine in terms of polyps and cancer. It's beyond the first year level. You don't need to remember these very well, but familial adenomatous polyposis, FAP, that's one that comes up from Vinod's content. And you should just be aware that, it's a mutation in the APC gene. They get lots and lots of polyps and they're predisposed to get cancer. But there are other conditions like Peutz-Jeghers syndrome, where you get these hamartomatous polyps, and as well you can end up with cancer. The thing you should also know about for colorectal cancer is age is important. Polyps are important, family history is important, but these hereditary syndromes are also very important. So presence of FAP, or another one called hereditary non-polyposis colorectal cancer, HNPCC, that's also known as Lynch syndrome. And the way I remember that is this acronym CEOP. Colon, endometrial, ovarian, and prostate is actually what the P is for. Pancreatic cancer is higher in Lynch syndrome, but I actually meant to write prostate here so that there's an equivalent for men. This comes up a lot in women's health. If someone comes in with endometrial cancer, we'll ask about a family history of colon cancer at a young age, because the Lynch syndrome could present with colon or endometrial or ovarian cancer very commonly. The other details here aren't, crazily important. Maybe just remember that the gene in Lynch syndrome is this MSH2 one, which comes up in the pathophysiology of other forms of colon cancer. The most important thing to take away from colon cancer is this slide, where the right-sided tumours in the ascending colon and cecum, they present with iron deficiency anemia, but they don't have sort of really severe bowel habit changes because it's so early in the colon. The feces are still liquid at that point. But they can get melena, the black tarry stools, and diarrhea. And if a patient has iron deficiency anemia, you need to rule out cancer, even if they have hemorrhoids or diverticulitis, to suggest that's where the blood's coming from. You really should do a colonoscopy to make sure they don't have cancer as well. Left-sided cancers are caught more early because they protrude into the lumen and they change your bowel habits. They cause blood-streaked stools, abdominal pain, and if it's down more distally to the rectosigmoid region, you can get frank bleeding from the rectum, rectal pain as well, and that can, even in an ultra-low rectal cancer, you can actually feel that on digital rectal examination. So left-sided cancers bleed, and you can really frankly see the blood. Right-sided cancers, it's kind of you can't really tell it's happening so well. You'll just have anemia, feel a bit unwell, maybe have some vague abdominal symptoms. To sort of round out the large intestine, here are some volvuluses. So midgut volvulus we talked about, and then for the large intestine you've got cecal volvulus and sigmoid volvulus. And it's all really to do with, for sigmoid volvulus anyway, if you've got constipation and a heavy load of feces in the sigmoid, that weight will make it rotate around itself. Volvulus is a really good topic to understand, and this is the coffee bean sign of sigmoid volvulus. To finish up the large intestine, let's talk about Hirschsprung's disease. So in babies that fail to pass meconium and then get a distended abdomen with bilious vomiting because the obstruction is distal to the duodenum, so that means bile will be present in whatever they vomit up. They have a tight anal sphincter, and basically it's an interesting form of chronic constipation secondary to the failure of migration of neural crest cells into the distal colon. So you don't get the proper innervation, and you end up with this sort of pathologically dilated but paralyzed segment of the distal colon. So that's Hirschsprung's disease, and you should know it really well. Let's talk about some important clinical aspects of the gastrointestinal tract. Firstly, let's talk about the acute abdomen. So someone that has abdominal pain, your approach of sort of remembering things, the easiest one is just the quadrants. And then it kind of becomes more specific with epigastric pain and suprapubic and periumbilical pain. But you can just start with quadrants for now. The right upper quadrant has the liver and gallbladder. The right side, posteriorly, has the kidney and ureter. Above the right upper quadrant is the lung. Put all that together, and if someone has pain in the right upper portion of their abdomen, it could be liver, gallbladder, kidney, ureter, or pneumonia. Okay. If someone has inflammation of their diaphragm, the pain will typically refer to the shoulder tip, because the shoulder tip is the C4 dermatome. And as you know, the phrenic nerve is C345. Left upper quadrant pain, you've got your stomach there. Again, you've got a kidney and a ureter, and you've got pneumonia. So gastric ulcers, for example. Right in the middle, epigastric pain, you could have a duodenal ulcer, or a gastric ulcer, really. You could have gallbladder, pancreas, or heart attack. So pancreatitis is characteristically epigastric pain radiating to the back, but myocardial infarction pain can be epigastric, and so can gallbladder pain. If you go then to the lower quadrants, you think, well, what's in each quadrant? You've got the ureters, you've got your inguinal canals, you've got bowel, you've got bladder and kidneys, you've got whatever your gynecological or testicular things are. And so put all that together, plus the appendix on the right side and the diverticulum typically on the sigmoid on the left side. And you've got right lower quadrant pain as appendicitis, kidney stone, UTI, Crohn's, for example, a hernia that's become strangulated and painful, or referred pain from testicular torsion, or ovarian torsion, or a ruptured ovarian cyst. Left lower quadrant, you've got diverticulitis, you've got, again, the urine and the stone, hernia, ulcerative colitis, typically on the left lower quadrant, and again, ovaries and testicles. Right above the sort of suprapubic region and around the belly button in the periumbilical region, that's where you could have bowel obstruction, appendicitis before it's become somatic. Remember how it starts periumbilical and then migrates to the right lower quadrant, or an aortic aneurysm. So the best way to approach abdominal pain is to look at how sick the person is. When you examine them, do a bit of percussion to see if there's any peritonism. Then you've got your specific signs for appendicitis and whatever. Check that there's bowel sounds, and then ask yourself, could this be something life-threatening like aortic aneurysm, or reproductive threatening like testicular torsion? Could it be a really serious appendicitis, or is it just something like celiac disease? But the best way to approach it is to rule out the really scary stuff first. So, someone in epigastric pain, don't just assume it's indigestion. Do an ECG and rule out a myocardial infarction as best as you can, yeah? So practice this stuff again and again, and eventually, you'll look at a person's abdomen and you'll be thinking of all these things as you palpate the different areas and, you take the history and, for example, someone who has a cough and right upper quadrant pain, you go, well, maybe it's pneumonia. Someone with pain that gets worse when they eat and better when they take an antacid, maybe it's an ulcer. Someone with crushing retrosternal chest pain that they're also feeling in their epigastric region, get an ECG, do a troponin. Upper GI bleeding. The digested products of red blood cells in the upper GI tract will cause an isolated elevation in urea that's independent of reduced renal function. So in someone that's got normal creatinine but a high urea plus anemia, very, very high chance that they have a bleeding ulcer in their upper GI tract. They'll be anemic on examination, and then you'll confirm that by seeing that they've got a low hemoglobin. Typically, it'll be a microcytic hyperchromic anemia. They'll have melena, which is dark tarry stools, which is from the breakdown and oxidation of blood throughout the GIT from the upper GI coming out in the stool. And it could be things like ulcers or cancers, some other causes as well. Upper GI bleeding is technically anywhere from sort of, I believe, the mouth to the ligament of Treitz, which is sort of just after the duodenum where the ileum begins, the jejunum begins. Lower GI bleeding is basically from the jejunum to the anus. Again, you'll be anemic because you're bleeding. But if it's quite low down, you could have bright red blood or stool on the toilet paper. You could have hematochezia, which is that frank blood from the rectum. Or if it's higher up in the colon, you might not have visible blood, but it'll be present on fecal occult blood testing. And as we said, in any patient with anemia and changing bowel habits, you should offer a colonoscopy to exclude colorectal cancer. Things to consider would be Meckel's diverticulum, polyps, cancer, diverticulitis, and then if it's frank blood and it's there when they wipe with the toilet paper, consider hemorrhoids, fissures, rectal cancer, and anal cancer. Finally, let's talk a little bit about anemia, and then we'll talk about bowel obstruction. The approach to anemia is basically, firstly, you've seen that they have a low hemoglobin. So then you want to check, and this is, you don't do this for everyone, but if you want to figure out exactly why they're anemic, this helps. You check their reticulocyte count. If it's low, it means the bone marrow is failing to produce new red blood cells, so it points you towards an aplastic anemia from bone marrow failure. For example, they might have leukemia that's invaded the bone marrow and killed your cells that are meant to be producing red blood cells. If the reticulocytes are high, that's great. It means the bone marrow is working perfectly. So it must be something outside the bone marrow that's causing the anemia. Things that cause bone marrow failure are drugs, infection, autoimmune diseases, cancers, and what you call the hematinic nutrients, B12, folate, and iron. Peripherally, you could be bleeding, and the most common place is, an occult bleed in a GI bleed into the stool, urinary tract bleed, which can be kind of invisible, or hematomas. If, say, they're an elderly person that's fallen and fractured their hip, there could be, a liter of blood inside their leg that you hardly even know about. And then hemolysis. If it's not bleeding, it must be destroyed. And that could either be inside the vasculature or it could be outside of it in the spleen. And there's lots of different conditions based on that. You can then do a hemolysis screen where you look for high bilirubin, high LDH, suggesting cell lysis, reduced haptoglobin, which is a protein that gets used up when there's hemolysis, and a direct GUMS test, which can tell you if there has been hemolysis. And you can read more about the GUMS test because it also comes up in pediatrics and women's health for hemolytic screening. Let's finish on bowel obstruction. So you've got dynamic and then adynamic, or mechanical and paralytic. I prefer mechanical and paralytic, but I think dynamic is the word Griffith uses. In the paralytic, it's basically paralytic ileus, where something has happened that the neurological function of the bowel has shut down. So there's nothing mechanically blocking it, it's gone to sleep, and eventually it will get better. It's typically from drugs or blood supply or recent surgery where the bowel has been upset. Dynamic obstruction, or mechanical, can be broken into the small bowel and the large bowel. And in both cases, you've got something physical blocking the passage of stool or intestinal contents. The most common things in small bowel are adhesions, especially if you've got prior surgery, but also incarcerated hernias can be common, and then all the other rare things, and you should always think of cancer. Large bowel is very commonly cancer, but it could be volvulus or fecal impaction from long-term constipation and dehydration. Both will present with a colicky abdominal pain, which as the waves of peristalsis meet that dynamic obstruction, you'll get pain with each wave, so that's why it's colicky. You'll vomit, because obviously if things aren't going out that end, they'll come up the other end. If it's bilious and it's very early on with the pain, that suggests that it must be the small bowel that's blocked, because if you've got the large bowel blocked, you've got all that extra intestinal tract for the food to go down before you'd even consider vomiting. But if it's like a bilious vomit that came on 30 minutes after a severe colicky, midline abdominal pain, that's really suspicious for small bowel obstruction, especially if someone's got something like Crohn's disease. Obstipation, meaning no flatulence, and then constipation. Distended abdomen, which typically large bowel will be more distended first because the large bowel can stretch much greater than the small bowel. And you'll get a high-pitched tinkling bowel sound, which is suggestive of that blockage. And then eventually the bowel will give up and you'll have no bowel sounds. On imaging, you'll see a transition point, which is where you go from the normal bowel to the obstruction, and then everything's collapsed distal to the obstruction. There won't be any gas in the rectum. There might be air fluid levels if you've taken an erect chest x-ray. And then you might see the cause of the obstruction. So you might see a big tumor, you might see coffee bean sign, or whirl sign is a good one to know on CT scan for volvulus. You might see a hernia, and you might be able to visualize adhesions on a CT scan. The thing that you need to understand is clinically there's basically colicky pain, and if it's small bowel, it's very commonly right in the middle at the periumbilicus. Small bowel is earlier than large bowel because it's a shorter distance for things to get blocked in. Bilious early on with a big vomit, whereas large bowel, obviously you've got extra space, so you don't have such a big vomit, but eventually you will get feculent vomiting where feces travels up into the stomach and gets vomited out. You get the very early constipation when the large bowel is blocked. When the small bowel is blocked, it's things can still move that were already in the large bowel. Distension is worse in large bowel, but overall for both people, they will be dehydrated, hypovolemic, have a diffusely tender abdomen that's peritonitic, so when you tap it, they'll be really painful. They don't want to move around in bed. There's high-pitched tinkling sounds, there's a collapsed empty rectum, and it might be tympanic to percussion, especially in a large bowel obstruction with lots of distension. To manage them, you resus them because obviously they're hypovolemic, so you need to get them fluids. Pop in a big wide-bore nasogastric tube to suck everything out that's stuck in there. Rest their bowel. Give them IV analgesia and antiemetics, but not stuff that's contraindicated in obstruction like metoclopramide. So because metoclopramide makes your stomach and stuff move things along faster, it'll just make the pain worse because it'll promote peristalsis into that fixed obstruction. Gradually increase their oral intake, and if you have to, you send them to surgery. And that's everything for the GIT. Good luck in your exams. We'll get resp and renal out to you as soon as possible.